Everyone for joining our monthly webinar. As most of you know, these occur every month. I believe it's on the third Wednesday. We also have two other free webinars. We have the open call, which occurs on the first Friday of every month, and then also our Healing Together, which occurs quarterly now, beginning again in August. If you'd like to find some more information about that, please see the NARR website. But today we have the DePaul group joining us to present what factors might make recovery homes more effective. So I hope everyone enjoys, and without further ado, I'll give it to the DePaul group.
Thank you so much, Elliot, and thank you, NARR, for inviting us to talk about factors that make recovery homes more effective. And we're also happy to hear different questions that you might have. And we're certainly going to try to be as responsive as we can to some of the things you might have interest in. All right, so just trying to advance the slides, and of course the slides aren't, there we go. So yeah, so I'll be asking Alexander to kind of take the next slides. And so what do Recovery House members say are their most important goals? And if you ask them, which we did over 15 years ago, certainly substance use and abstinence is critically important. But if you look at the two most important ones, it's actually highest rate of growth, increased feelings of social connectedness, greater personal sense of community, a new tolerance for others that are different from oneself. And the second most important thing was accountability. Through rules and structure of the house, there's an internal organizational structure that's about mutual accountability for non-drug use. So we certainly see that there's important things besides abstinence that people spend time in these recovery homes. And as I'm certain everybody who's operators know that. Okay, next slide. So in our group at DePaul University, we basically first wanted to find out, do recovery homes work? We did 2 randomized studies. Next slide. So just to review real quickly, we had people coming out of substance use treatment. They went into a recovery home or not, followed them for 2 years. And those who had the recovery home experience, and this was more of a self-help Oxford House type, had higher abstinence rates, 69% versus usual aftercare, 35%, higher monthly income, almost twice that, and significantly lower incarceration rates, only 3% versus 9%. Next slide. In a second study, we focused on criminally justice involved individuals who had substance use disorders. And again, they were randomized to recovery home, therapeutic community, or a control condition. And at the 2-year follow-up, the recovery home achieved significantly higher continuous alcohol sobriety rates. And the net benefits per person were really astounding. You can see over $12,000 for the recovery home, $3,000, a little bit more for the control, and for therapeutic communities was actually a minus. Next slide. One of the things we very early found was that tolerance actually improved. So this is very important. So it's not just, again, people trying to stay abstinent. It's also changing the type of person one is and being more tolerant of other people who are in the house and actually outside the house as well. Next slide. One of our early findings was, and Alexander will be talking a little bit more about the networks is that those who stayed in for 6 months had really terrific outcomes 2 years later. And the best predictors of who stayed in for 6 months was having a friend in the recovery house. So again, this really focused us on saying, if we want to make recovery homes more effective, more facilitating positive outcomes, how do we basically understand friendships, make sure everyone does have someone that they're connected with when they come into the house? Next slide. So really what this comes down to is changing persons, places, and things. As you all know, that's what recovery homes do so well. Next slide. And this is just, again, some of our early work. If you can see on the left, you can certainly see this ego, which is the person that we were studying, and the friends, sisters, mom, brothers that are in red. These are people who are substance using, and the green are people who are abstinent. So you can see this person's ego, this network, is really filled with people that are using. But 2 years later, after being in a recovery home, you can see very few users. Most people are non-users that are influencing the ego. And that's what the power of recovery homes are, changing the types of people that you're with. And that's what I think really the ideal is with our recovery home work, to sort of see how do we change these social connections. Next slide. So being friends with others who are more recovered seems to improve one's own recovery, and seeking advice from those who are more recovered leads to increases in recovery. These are two findings that have come up repeatedly. So again, it's not just having connections, but hopefully those who are coming into the house and new, how they can have connections with those who have more information, experience, wisdom, so that they can basically increase their own recovery. Next slide. So the question we were asked to really bring up during this webinar is, what makes recovery homes effective? And they're not just places to live, they're also social environments that can strengthen recovery, accountability, and belonging. Next slide. And the core idea is, can a recovery home work when the house functions as a healthy, recovery-oriented system? So recovery homes can improve abstinence, stability, community reintegration, but these outcomes depend on more than a bed, curfew, or referral system. What matters most is the day-to-day social environment, relationship norms, shared responsibilities. And for NARR operators, the practical question is, what home-level factors can we actively strengthen? Next slide. So these are 5 things we're going to basically talking about. They're highly relevant for NARR residents because operators can influence all 5 through structure, expectations, and culture. Next slide. So the social environment is the intervention. Residents do better when they're embedded in supportive, recovery-oriented peer networks. Recovery can spread through everyday contact, modeling, mutual accountability, and isolation, weak ties, or disengagement can increase risk. So operators should pay attention not only to individual residents, but to the fabric of relationships across the whole home. So healthy homes create repeated positive contacts. For example, meals, meetings, chores, check-ins, peer support. So connection, belonging, shared norms, mutual accountability, this all is the intervention. This is what the social environment is, and this is what we're trying to enhance. Next slide. The network structure matters. So mutual relationships support trust and accountability. Cohesive networks reduce the chance that residents drift to the margins. Recovery-oriented residents can influence the broader house culture when they're central and engaged, and cliques that exclude others can weaken house functioning. So what are the implications for NARR homes? Make the integration intentional, especially for new residents. So use peer mentors or buddy systems. Watch for isolation the first 2 to 4 weeks. create repeated opportunities for residents to work together. Next slide. So the third factor, governance shapes recovery behavior. So governance is not only administration, it affects ownership, participation, accountability. And you'll hear more about this when Liz talks about governance in homes, but the more resident-driven homes, the greater the ownership, more peer accountability, and stronger recovery identity. So for many NARR homes, even with staff presence, resident voice can be expanded. Shared decisions can be improved, and roles and responsibilities can build engagement. So these are some of the tasks that we'll be talking about. Next slide. So what does this mean? You may not use a fully self-governed model, but you can still design for participation. Operators can strengthen outcomes by creating structured resident voice rather than relying only on top-down rule enforcement. The more residents help shape the culture, the more likely they are to protect it. And NARR alignment does not require one model. It requires quality, safety, and a recovery supportive social environment. So resident-led agenda items are house meetings, rotating responsibilities, peer mentorship, transparent conflict resolution, recognition for contribution. So these are the things that NARR operators can be working on. Next slide. The fourth issue, which will also go into more depth with Aron, we'll be talking later, residents do better when they feel they belong, when they matter, and are responsible to one another. Belonging supports retention. Mutual support strengthens resilience, and shared mission improves consistency of norms. Community identity can turn the program into our house. Use rituals and traditions. You can celebrate milestones, set shared goals for the house, make meetings meaningful, not perfunctory. Next slide. And the last factor that we'll have Carly talk about a little bit later is recovery capital. What does that mean? What is social capital? That's support of peers, sober role models, recovery connections. It's personal capital, confidence, coping skills, responsibility, self-efficacy. It's community capital, access to services, employment, transportation. So one of our good colleagues, David Best, has talked about this strong recovery home does more than keep people stable. It helps them gain resources they did not have before. So one question you can think about is, if residents are leaving with more connection, confidence, and capital than when they arrived, and if their recovery capital has improved when they're in the house, there's good likelihood that it will continue to improve when they leave. Next slide. So these are common risk factors that reduce effectiveness, and you probably have all experienced this in houses or heard about these experiences: resident isolation, exclusionary cliques, weak or inconsistent norm enforcement, low meeting engagement, high turnover without integration, staff solving every problem for residents. These are the types of things that we want to reduce in the homes if possible. Next slide. So what's a high impact practice? Improve onboarding and integration. So you can assign a peer mentor or buddy. You can explain house norms through conversation. You can include new residents quickly in meals, chores, and meetings. You can check for social connection during the first month. So the goal in this first practice is move a resident from an occupant to a member as early as possible. And it matters for NARR homes because early belonging can improve retention and reduce conflict. And certainly these slides that I'm talking about, and thank you for some of the comments that are being made. And these particular slides Um, I'm sure we will make them available. And Elliot, if it's possible to make these available, we're happy to do so. So that, you can certainly use them wherever you'd like, in your own settings. So I think this recording, so yeah, great. And thank you for that comment. Next slide. So what's a second high impact practice? Make meetings matter. Use meetings to solve real house issues. Invite resident-led agenda items. Review expectations and celebrate progress. Create consistent follow-up on decisions. So meetings are one of the clearest places where culture becomes visible. If meetings are passive, residents disengage. If meetings are meaningful, residents practice accountability and voice. Next slide. So what operators should watch beyond abstinence? Are residents connected to one another? Do residents become integrated quickly? Do residents participate in decisions and roles? Is there a strong sense of fairness and accountability? Are residents gaining recovery capital? So you don't want to just measure compliance. If you do so, you might miss the social conditions that drive long-term success. So these are all the background framing issues that make the homes that are managed even more effective. Next slide. So what's the bottom line? Strong recovery homes create connection, not just residents. They build participation, not just compliance. They reinforce accountability, not just surveillance. They increase recovery capital, not just stability. So the house is a recovery mechanism when relationships, norms, and shared responsibility are strong. Next slide. So, trying to summarize what I've been bringing up is the effectiveness of recovery homes is not just about rules, services, or buildings. It's about how people live together. For NARR operators, one of the most powerful interventions is the social system you create inside the house. Next slide. I'm going to turn things over to Alexander Sikora, who's a first-year graduate student in the clinical psych program at DePaul University in Chicago. Take it away, Alexander.
Awesome. Well, thank you very much for that introduction, Dr. Jason, and good afternoon, everyone. Like you said, my name is Alexander Sikora, and today I'm going to be talking about social networks inside recovery housing. Whenever I tell someone I'm a social network researcher, they always think I'm at Google or Twitter or Facebook. But in reality, what I do research is real relationships. How residents in recovery homes share trust, who they turn to, who they avoid, who they support, who supports them back. And in recovery housing, these relationships are not just kind of the background details, something that Dr. Jason was talking about. They're actually part of the recovery environment itself and are some of the things that make recovery homes so successful. For operators, this matters because the strength of a recovery home is not only determined by its rules, structures, or policies. Those things are important, but the relationships inside the house are often what truly make it either supportive and recovery oriented or fragile and disconnected. All right. Now, why is it even important to look at the relationships inside the home? Touching on what Dr. Jason said again, we found that those who stayed in a recovery home for at least 6 months reported greater recovery over time. This was a key indicator that let us look in what is it that makes a resident stay in the home for at least 6 months. And we found the most important predictor out of all the things that we were assessing them for was having a friend inside the recovery home. And this led to them having that 6 month stay, which led to those greater recovery outcomes. So, for the past decade at the Center for Community Research here at DePaul, we've been studying social networks in recovery homes. Now, I just want everybody to kind of reflect quickly. You could send either a message in the chat or you can unmute quickly and kind of throw something in. I just want you to think of kind of the strongest recovery home you've ever been a part of, you've ever run, or you've ever visited. Um, what is it that you think made those relationships truly different inside? And I'll give everyone a few seconds. All right. Seeing things pop into the chat. Fantastic. Yep. These are all excellent points. A common goal shared among the residents seems like true care for each kind of resident within the home, going to meetings together, being authentic. These are all key aspects. You can see these are things that are hard to measure. These are things that are all part of relationships and social bonds within the home. And this is one of the reasons it's so important to kind of study these social networks within the recovery homes. These social networks are not just kind of the background context, they're active mechanisms of change, and they have the predictive power to show who's going to be successful within a recovery home. Like we talked about, friendships and social bonds strongly predict your length of stay and long-term absence outcomes. We also see that kind of advice seeking and resource sharing relationships. These are just like friendships, different levels of relationship you can have within a home. That these kind of build the essential trust and cohesion that makes a house stable um, inside a recovery environment. And this structure really does matter. When we talk about these social network relationships, one of the most important indicators of a strong home is these reciprocal relationships. It's not that there's one person who thinks everybody inside the house is their friend. It's that everyone within the house kind of thinks each other is their friend. It's kind of going back and forth. And it's key to look at these types of relationships, especially when we think of where do we see residents kind of seeking support inside the house. So, another thing we can just kind of throw some things in the chat. In your house, who do you see residents actually go to when things get hard? Are they reaching out to higher level staff? Are they looking for peers in the house? Or maybe are they reaching outside the house for family members? Yep. I love that comment, Rachel, all of the above, because it's something that we've seen in our research. There's no one right answer for where you go and seek your support. We've looked at this at many different levels. We've looked at people, we saw that you can have successful recovery outcomes if you reach out to someone inside your house. Having those dense mutual social connections inside your house tend to predict higher recovery capital over time. But we've also seen people who reach outside the house to close family members, and they still have that successful recovery capital over time. And this kind of shows that it's not necessarily important exactly where you're seeking the support from. It's just important that you're receiving the support from somewhere, and it can be interchangeable. So, no house structure has the exact perfect way for everybody. And as you all know, no one's recovery journey is the same. You can't just have a blueprint that perfectly plans it out for everybody. Everybody has an individualized experience, and there's many ways to kind of build those social connections over time. Now, I'm going to give you a couple examples for how we study this. This is just a look at a dyad. These two circles, when we're talking about social network research, we get these plots, and these two circles represent two residents within a home. And we have resident A and resident B. The arrow in between them, this indicates that resident A is willing to lend resident B resources. And as we go on to the next slide, we can see this can go both ways. Now we see that resident D is willing to lend resident C resources, and that's the direction of the connection. But like I was saying before, the most important connection we want to see inside these homes are these reciprocal relationships. And this is what true reciprocity looks like inside the homes. It's when resident E and resident F are both willing to lend resources to each other. This shows a strong and supportive recovery environment. And this can be across all dimensions. This can be on friendship, willing to loan resources, advice seeking relationships. When you have more dense and mutual connections, you have less isolation and fragmentation in your house. People are connected, they can reach out to others for support, and that helps sustain successful recovery over time. Now, one of the areas that we focused on for a while was looking at kind of people who may be stigmatized within a home and see how their social networks look to compare to others. So for this, we wanted to see how it looked for a resident who was utilizing MOUD inside a house's social network and how it looks for a house without a resident on MOUD. We know historically there's been some tension or stigma around MUD and absent-based recovery environments. So it's interesting when we looked at this, we hypothesized that we'd see kind of negative relationships when we looked at this. But what we found was actually encouraging. In houses that had a person on MOUD, there was more reciprocal lending resources over time and more mutual friendships over time. And here's an example of one of those homes. We have the blue dots. These all represent different residents within the house. And then we have the arrows in between them showing the directions of the friendship. So this blue dot here thinks this blue dot's their friend. This red dot here, representing someone who's utilizing medication for opioid use disorder or MOUD, thinks they're their friend. But you can see there's no arrow coming back. There's no arrow coming back. The MOUD resident had a lot of one-way connections when they first entered the house. But after just 4 months, we saw that they had 100% reciprocity in this house. And this was repeated over time for all of the houses with a resident on MOUD, showing that it was actually a protective factor to have someone like that in the home. We've seen this at varying different levels of relationship where people might think that stigmatized. We saw this with people who had severe psychiatric comorbidities. They actually were able to have successful recovery as long as they were in a socially supportive recovery environment. So these social environments are able to kind of pick up almost anyone from where they are and carry them over to recovery success. So the last thing I want to leave you guys off with is what's one thing you think you can change in your homes to help naturally foster this kind of social connection? Dr. Jason gave some great examples for how to kind of lay out this structure, but I think it's important to always keep this in mind because recovery environments aren't, our recovery homes aren't just meetings, um, just a manager making sure everybody's staying accountable. It's actually those successful connections, those building of sober networks of people who support you in your long-term recovery. So it's something that like everybody to think about as we carry on through this presentation. Next, I'm going to turn it over to one of our research assistants here, Angelina Lee, and she's going to talk about MOUD use in recovery residents a little bit more in depth. Angelina?
Hi, everyone. Thank you for that introduction, Alexander. I'm going to be building off of what Alexander was talking about with MOUD use and recovery residences. Next slide, please. So to begin with, opioid use disorder is considered a public health emergency. It results in tens of thousands of deaths per year, and it also is implicated in over 70% of overdose deaths in general. But MOUDs are an effective form of treatment for opioid use disorder that can provide a multitude of benefits, including a decrease in opioid cravings and withdrawal symptoms. They can lower relapse rates, decrease the risk of contracting viruses from harmful behaviors like intravenous drug administration and sharing injection equipment. They can also help end opioid use altogether. Next slide, please. So, as Oxford House updated its policy to endorse the use of MOUDs within the recovery home, and then NARR also issued guidelines on how to support individuals taking MOUDs within the recovery residence in 2018. Evidence is pointing to the idea that recovery residences can be assets that support the recovery process alongside MOUDs. For example, one study found that living in a recovery residence helped individuals prescribed MOUDs be in control of their recovery and also adhere to their treatment. And this is especially important as most individuals who have opioid use disorder only receive short-term care. And only receiving short-term care can increase your likelihood of relapse. So recovery residences can promote longer-term symptom management, which can then help build more lasting skills in your recovery journey. Another study also found similar abstinence rates across individuals who were using MOUDs and individuals who weren't within recovery residences, suggesting that recovery residences foster abstinence outcomes. So overall, the overarching idea is that living in a recovery residence can build a sense of community, especially through the diverse environment from individuals who are also taking MOUDs and can relate to those experiences, but also individuals who aren't taking MOUDs but still provide that peer support that contributes to the sense of belongingness and community within a recovery residence. And all these factors together then increase your likelihood of staying longer in a recovery residence and build those lasting skills for your recovery journey. Next slide, please. So these studies here were based on interviews with individuals who were taking MOUDs within recovery residences. And what they found were the most helpful things that operators did for them in the recovery residence and what fostered the most optimal outcomes for their recovery journey. And essentially, they found that operators played a critical role as the bridge, connecting individuals to integrating into the residence in a variety of ways, from being the person who connected them to the appropriate providers, or just providing comprehensive support throughout their recovery journey. So one thing that they mentioned was that peer education and training that involved empowering the voices of individuals who have had success with MOUDs was really important. Increasing understanding of MOUDs and how they work and what they are can reduce stigma, which can then lead to attitude shifts and more acceptance of individuals within the recovery residents who are taking MOUDs, and thus contribute to the overall sense of community that residents have. Operators can also help residents navigate resources, especially as the healthcare system can be really complex and burdensome to navigate. And so they can help by making the referrals to providers so that individuals are able to access the care that they may not have been able to before. But also, operators can play a critical role in increasing awareness of MOUDs and presenting them as a viable option for people with opioid use disorder. Operators can also play a role as active supportive community members by setting an example for positive attitudes towards individuals who take MOUDs and contribute to the reduction in stigma. And they can also engage residents through collaboration, such as incorporating residents' voices in decision making through making recovery plans. This can also happen through including residents' input in conflict resolution. And then also sharing lived experiences with residents can help build trust as well as mutual understanding between operators and residents. Finally, staff can help residents overcome common barriers to MOUD access. This can be through provision of housing, of course, but also some recovery residences may have the infrastructure necessary to provide transportation to opioid treatment programs that residents may not have been able to have access to before. So I just wanted to end off with asking about your own personal experience in the recovery residence and how do you best support individuals taking MOUDs?
So thank you, Kate, for that comment, and Angelina, terrific overview. And again, as we are showing social networks, and basically these are all terrific ideas. Thank you for your comments. And Angelina, really this MOUD is such an important thing for how we can help patients, the residents of these houses, just have a better chance being successful. All right, on to the next person. We'll hear from Liz at this point. Liz?
Yes, hi everyone. Thanks for letting me speak to you today. I'm a research associate at DePaul, and I received my master's in research psych under the advisement of Dr. Jason. And today I'll be talking to you a little bit about resident and engagement and voice, which Dr. Jason had a little bit of an overview prior, so we can get right into it. Next slide, please. So, in terms of looking at house stability, there are a lot of factors in what promotes a house being really successful and what maybe might consider a house to struggle. We created a study because we really wanted to assess the factors of what can make a house sustainable? How can we prevent potential relapses or house closures in this process? And we created this study that really identified 4 different stages of stability in recovery housing. So we went into this study thinking that those stages would be survival houses, stable houses, successful houses, and significant houses. And our perception was that survival and stable houses, they're really focused on surviving. They're struggling to pay rent. They're focused on finances, filling beds, whereas successful and significant houses are maybe more focused on recovery. The conversations in the house are about recovery. There aren't as many vacancies, and members are regularly talking to each other. So, in determining are these actual conceivable phases of a house, we conducted a study, and our findings were, next slide, please. We found that we were right in differentiating 4 different stages. Our results showed that team effort and communication in houses were very important in terms of stability. Houses that had financial problems or lack of rule implementation were houses that were considered less stable. And then those successful and significant houses were engaging in more self-help and social activities. For instance, there were more friendships in the house. Maybe those friendships were leading to more 12-step involvement. They were regularly attending meetings with their friends. And overall, we found that team effort was incredibly important, where there was a community and a sense of culture with engaging with others. Those were considered more successful and significant houses. They were on the top of the hierarchy of stability. Now, after we found these results, we really wanted to tap into how does resident engagement and voice play into that? What are the differentiations between what makes a stable house in comparison to what the residents are doing? Not necessarily just is the house stable because it's financially secure, but how are the residents' engagement playing into that stability? Next slide. So we conducted an additional study looking at governance and decision making in recovery homes. We wanted to assess a few different factors. So we created a survey and a validated measure that looked at 4 different dimensions. The first was rules. So this was the rules of the house. Members attend weekly business meetings. Obviously, there's the sobriety rule in there, right? No substance use within the home. Then the second factor we wanted to look at was decision making. Whether members were voting on rules in the house, how much control the residents had in decisions of the house. So, for instance, members vote on whether or not to accept a new member. Following that, we looked at implementing the rules. So this was to determine how the residents viewed how their perception of rules was applied based on their own needs. So perhaps if someone's setting a rule in the house because they feel that collectively it would help support them, they're going to view that decision as fair to them. And then house outcomes. So we wanted to look at how rules and decision making influenced the house culture. So based on, oh yeah, this is a strong sense of community within my house. The social climate inspires or motivates members. This goes beyond just the decision making, but really, what's the house culture here? Do people like each other? Do we feel like it's a community? And so we looked at all of these four dimensions and we wanted to see what we would find. What was the perception between the rules of the house versus the outcomes of the house? Next slide, please. So we actually found that the more someone made decisions in a recovery house, the more that they viewed the recovery house as a positive environment. And rules that were more fair or perceived as fair were made collectively. And this was the ability to create a great space and focus on recovery where people felt like they were engaging with the rules of the house. So overall, our lessons learned during this study is that resident engagement and voice promote social connectedness, trust, and overall stability in the house. Having a say in recovery can be crucial to building the foundation of a recovery house. So in the context of different NARR homes, finding an ability to have an open connection and conversation with how rules might affect residents can really benefit their ability to connect long term, stay within their house, and promote their own recovery. And that's what I have for you today. Thank you very much. And I'll pass things off to Carly, who is a research assistant at DePaul as well.
Yes, thank you, Liz. I'm Carly. It's great to be here today. I will be talking a little bit about recovery capital. I'm sure most of you are quite familiar with this term and this concept and use it in your day-to-day lives as operators. It's also something that we study here at our lab. Next slide, please. So if you don't know a little background on recovery capital, it was kind of drawn from the social capital theory, which was kind of described by a sociologist named Pierre Bourdieu around 1985, who defined social capital as the actual or potential resources acquired by individuals through their relationships with others. So two sociologists, William Cloud and Robert Granfield, in the 90s, kind of drew on this theory of social capital to answer a question that they had that's pretty common in substance use recovery, which is why does one person able to maintain recovery while another person is unable to do so? And through a series of pretty intensive interviews with individuals who had successfully maintained recovery without the formal substance use treatment or mutual help programs, they discovered about 4 dimensions of this recovery capital that individuals can draw upon to kind of maintain recovery. And today, in our lab, we use recovery capital among 3 dimensions. So as Dr. Jason discussed earlier, these personal, social, and community factors. Next slide. So the kind of broad definition of recovery capital would be the internal and external resources that can be drawn upon to initiate and sustain recovery. And every individual has a different level of recovery capital. Next slide. Cloud and Granfield kind of sought to define recovery capital and explore it in this way because it's an alternative to a more traditional abstinence-based view on recovery, where more of the physiological outcomes or experiences or dimensions of recovery are focused, and individual different experiences are not looked at as much. And recovery capital kind of accounts for this social fabric or the social context that everyone exists in. And by looking at recovery capital, I think specifically as treatment providers or operators, one can kind of understand and examine the specific and unique set of needs for each resident. Next slide, please. So I think one of our studies that really looks at recovery capital in a pretty significant way is this one study where we looked at individual and house level recovery scores on the likelihood of relapse. So essentially, we took the recovery scores or the recovery capitals of individual residents, and we looked at their impact on the likelihood of relapse. And then we took, at the house level, the average of the recovery scores of every resident in that house to create one average recovery score of the home. And we looked at that house recovery score in relation to house-wide patterns of relapse. And we found two pretty important things. The first is that these indicators of recovery capital, so these personal traits or these social relationships, these are all correlated with each other. So that means that a resident that may score lower on one indicator of recovery capital, for instance, employment, if they score lower on employment, likely they will kind of have lower scores across other dimensions of recovery. So if you work with a resident to find employment and kind of increase that area of recovery capital, likely their entire average recovery capital will go up. I think the second finding that's pretty important is that when we looked at the predictions of relapse, house level recovery scores were significant predictors of relapse, and individual level recovery scores were not. So I think this really underscores what Alexander and Dr. Jason were talking about as the recovery home or the social environment as being very, very impactful and significant in one's recovery. So if you have a resident who may have a lower recovery capital, their recovery can still be bolstered if they are surrounded by peers with higher recovery capital. Next slide, please. So knowing this, knowing that the recovery home is a very, very, very vital part of one's recovery, houses can, we've discussed these, I think everyone else in the presentations before, but what are some ways that houses can kind of implement things to grow recovery capital? The first is this, again, idea of the social context and the social environment. So really, we found that a strong house culture and a sense of community among residents is really related to higher recovery capital. So regular house meetings, peer support and mentorship within the house, recreational activities. Another thing that we found through various studies is that if you focus on financial or employment aspects of this recovery capital, you see a growth in overall recovery capital. So helping residents with resume building or mock interviews or financial planning. And then lastly, Liz just talked about it, but we really see when residents are feeling more involved and more responsible within their homes, that leads to a better experience in the house and better recovery outcomes. So just like she was talking about, delegating responsibilities, enhancing decision making, and just really creating that culture of shared investment in the home. Next slide. So another question I wanted to pose, if anyone wants to throw anything in the chat, if anyone has any insights or if there are any specific ways in which they've seen growth across the recovery capital of their residents. Okay, and then I will throw it over to Aron.
Hi, my name is Aron. I am a graduate student working for Dr. Jason in his lab, and today I am going to talk about psychological sense of community in recovery housing. So first and foremost, we have to look at the definition of the psychological sense of community. What does sense of community mean? So next slide. So previously, Saracen has defined psychological sense of community as perceived similarity and interdependence with others, and a willingness to maintain this interdependence through actions. So in other words, Sense of community means that you feel belong to a group. You see among the people in the group similar values, similar shared values, shared goals, shared responsibilities, and that you receive and provide help to other people in that very group. So that is a part that is maintaining that kind of interdependence. Further research, Dr. Jasons and his colleague also identified three components of sense of community through his construction of these psychological sense of community scale. These three domains include the self, which includes the identity and importance of self, membership, which is this concept tap into the social relationships between the people in that group, and lastly, the entity, a group's organization and purpose. And so now that we know the definition of the sense of community, how does it relate to recovery itself? So recovery, in essence, is a multidimensional outcome, but perhaps the outcome that we look at the most is the stopping of the substance use, which is behavioral. And so I have two theories, psychological theories or framework that I want to highlight to you. And the first one is Bandura's social cognitive theory. Next slide. So Bandura's social cognitive theory is a learning theory. This states that learning occurs through a dynamic interaction between personal factors, behavioral factors, and environmental factors. And in here, the sense of community will fit into the environmental factors and also the behavioral factors. Individuals in recovery can learn better behaviors regarding recovery through the influence of the environment, through observations of other people in their community. And that is also supported by a strong sense of community. And the next slide, please. And the second framework is something that is very common in the field of community psychology, which is Bronfenbrenner's ecological model. So similar to Bandura, Bronfenbrenner also said something similar, like a dynamic interaction between different factors. However, in this model, Bronfenbrenner showed that the individual is at the core and that behaviors are influenced by larger different dimensions. And these dimensions including the microsystem, the mesosystem, exosystem, and the macrosystem. In the case of recovery housings, the recovery housing fits into the microsystem, I think. And a strong sense of community will also promote the strength of influence of this microsystem on the individual's behaviors. Next slide. So you have the theoretical framework of the psychological sense of community. So through what mechanism can the sense of community influence recovery outcomes? Well, there are multiple mechanisms that the sense of community can influence recovery outcomes, but I'm going to just highlight three of the mechanisms that have been highlighted in previous research. So the first one is that recovery is supported by peers, allies, and then that is maintained by the Substance Abuse and Mental Health Service Administration. They emphasize that recovery, the main component of recovery, a very strong predictor of recovery, is social support by your peers and your allies. And one indicator of this strong social support is a strong sense of community. The second mechanism is that social sense of community can influence quality of life and hope. And both of these variables also predict a better recovery outcome. And in here, the sense of community impacts the recovery outcomes indirectly through quality of life and hope. And lastly, the sense of community predicted engagement with the recovery infrastructure, higher recovery social support and capital, self-esteem, and also decreased psychological stress. And all these factors are also very important to the recovery outcome as well. Next slide. So now that you know the theory, the definition, the mechanism, so what can operators do to build a stronger sense of community in the recovery housing? Well, taken from previous research in recovery and other areas, there are 4 strategies that I think would be relevant to you as operators. The first strategy is organization of community events. So sense of community is based on connection to other people in the group, and community events can provide the residents the space and the opportunity to interact and relate to one another beyond the focus of recovery. And through this, they can strengthen their bonds and their connection to the group and to the entity itself. These events can be very simple, like game nights or story sharings or something like that. And these events also can serve as important observational opportunities for the staff as well. So through this, the staff or the leadership can observe the residents in a more comprehensive manners, learning about their preferences or other things like that. And all of these information can help the staff provide and respond to the needs of the residents more effectively. And the second strategy I want to talk about is promotion of within network communication and interpersonal support. So one of the high impact practice that Dr. Jason highlighted is that meetings matters, and this also fall into that kind of high impact practice. And in here, when I'm talking about interpersonal communication and support, I'm not talking about just resident to resident, but also staff to resident and vice versa. The most important part is that residents should feel that their voices matter, that their identity is empowered, and that the people around them are willing to listen to them and are willing to respond to their needs. And this can only be done through effective and strong interpersonal communication and support. Third strategies involve improving infrastructure. These efforts can be either staff-led or resident-led, but regardless of whether it's staff-led or resident-led, the focus is on improving the infrastructure. So in a nutshell, this strategy aims at increasing the residents' sense of autonomy and ownership of the space itself. The goal of this is to promote connection to the entity, to the structure, and to the space, the housing, so that when residents think about the recovery house, they don't think that it is a recovery house, but rather our recovery house. And this will in turn promote engagement with the structure, with the social service, with social capital and the services that are available in the house. Something very simple like you can do would be like a spring cleaning, holiday decorations, or just reorganizing the things that are in the common areas. Again, I have to reiterate that it is important that residents' voice and preferences are accounted for in these efforts. And lastly, a sense of community can be promoted through recognizing and respecting the importance of religiousness or spirituality. Faith is very important in recovery, and extensive research has demonstrated that. And not only it is important to recovery, but it's also important to the identity of the residents themselves too. You can see a lot of programs like the Alcohol Anonymous. They have incorporated faith-based elements into their program. And so through recognizing and respecting the faith of the residents, you can deepen the relationship between the residents and the recovery structure. And again, like I said before, faith is also important to identity. So you're also promoting the self component of the sense of community. But yeah, that's it for my part. I wonder if you have any questions. Yes.
Well, Aron, thank you for giving us an overview of sense of community. And thank you also, Liz and Carly, Alexander, Angelina. I think what's important is all the pieces kind of keep weaving together. You sort of see so much overlap between the same issues, but they're also kind of telling us something about what's important and that we do have a role to play in actually enhancing the effectiveness of these recovery homes that you're working with under the NARR organization. But we're here now to have a little bit of time. If you have any questions that you have for us, we're kind of here to basically just try to be helpful and kind of share with you some of the lessons that we've learned over many years. And we thank you folks for allowing us to come into your settings and kind of ask questions and try to understand all the important things going on. As we know, there's something like 8,000 NARR homes and over 4,500 Oxford House homes, and there's probably twice as many of those homes out there as well besides that. So we're talking about thousands and thousands of places where people aren't being able to really find refuge. And what we're saying is that there are very high quality settings that are available to the public. So once again, if there are any particular issues that you found that's helpful, if there's something that we might have said that kind of sparked your interest, in terms of, feel free to message us and we're happy to think about it. Maybe to start things off, can I get the slides?
Yeah.
Well, Ellen, that's something that we're happy to share with everybody. Alexander, do you want to put a link in
Yeah.
to chat?
Yeah. I'll composite those. I don't have it available right now, but I'll connect with Elliot and have it send to everybody who's attending if that's possible, Elliot. But I do want to mention, Dr. Jason, we do have a question that popped up in the Q&A.
Okay, why
Um,
don't you throw it out to everybody?
all right. Yeah, Tiffany Knight was interested into what's the average length of stay for a person in a recovery residence? And it's a two-parter. After that, what's the success rate or average success rate for those who have gone through a recovery residence? And I assume this is versus usual care, or maybe it's just looking at overall.
So Elliot said, please put your email in the chat and we'll make sure those people who send the email to Elliot will get our slides and we're happy to make them available. And in terms of, it's a good question. Thank you for the viewer who mentioned that. Generally, people, there's usually about maybe, somewhere between 8 and 10 months would be kind of what an average stay might be. And certainly what we found is that the longer you stay, actually, the more benefits you get. So that's a good thing. And often, probably the most vulnerable time is the first couple of weeks to a month. So if you come into these settings and you basically feel alone and you feel like you don't really have a friend and no one to really kind of confide with, that's going to be really difficult. So there's going to be individuals who are going to leave. So if you leave the house within a very short period of time, there's probably not much of a benefit you're going to get. But if you do stay long enough, I would say that some of our research suggests that something like 2/3 of people are going to have a good outcome. And the longer you stay, what we found was that those folks who stayed for 6 months, when we looked at them for 24 months later, almost all of them did great. So if you can really stay that half a year, the really outcome rates are terrific. If you stay for shorter periods of time, then you're probably not going to have the same type of outcomes. So that's one thing we've learned. Any other questions that have been posted that we can be helpful on?
Yes, oh, sorry. I know that there was a question from Jessica, which I typed in the chat. For the stability study, Jessica was interested if it was Oxford House specific or if it was NARR certified. And I did answer that in the chat, but the preliminary study was with Oxford houses, but we've actually, from the second study looking specifically at governance and those factors of like decision making in the home, we actually did collect data from NARR certified homes. So we are hoping to publish that study as well, so that it can be a more collective understanding of decision making in all recovery homes.
All right. Well, thank you, Liz, for sharing that with us. Alexander, did you have a question that you wanted to throw out there?
Yeah. So one of the things I wanted to ask from all of us here are community psychologists. So one of the important things in community psychology is figuring out what it is the community wants. And I think this is a great opportunity since we have all of you guys here. If you guys had a study that was interesting in mind or something that maybe you want to know more about recovery residences or the recovery process in general, if anybody wants to maybe send a message in the chat or unmute, what is something that you would like more research done on, or something that you think might be overlooked in the field of recovery?
And we're very open to suggestions. And if you have particular ideas, both now and other times, you can feel free to email us. I'm at ljason@depaul.edu. So we've got a question. Robert, thank you. We have something that just came in. Alexander, I'll let you read that question if you can see it.
Yes. It looks like Robert said at Recovery Revolution in New Jersey, level 1 social model homes. They have 12 people in 10 years of operation who stayed for 18 months to 3 years plus. And when they left the house, they were actively mentoring someone in recovery. All 12 have not returned to use and are still on their recovery path. So that's interesting, talking about kind of the pure recovery model. It sounds a lot similar to something that I've recently learned about, kind of MAPS. I don't know if anybody's heard of that. It's mentoring peers in recovery for peers in recovery. It seems like it's kind of taken after that model, but that seems like a very interesting program that is set up there in Recovery Revolution in New Jersey.
So again, certainly changing people, places, and things is so important. So if you can learn how to change that in the recovery home, when you leave the recovery home, if you can stay with those people, peers who are actively promoting kind of your success and kind of maintaining a job, maintaining good relationships, trying to stay away from the alcohol and illegal drugs, then that's really critical. One question I think that came up earlier was, well, thank you, Dina. We'll let another person answer that question in a second, but one question was, what about residence size? I think that was asked. And we did find that, if you have more people in the house, something like 7 or 8 or more, you're actually going to do a little better than if you have fewer people. And that's probably more folks to learn from. And if you're kind of having to pay for the house with expenses, then expenses will probably be a little bit less, although that isn't always the case with NARR houses. So the reality is having more different type people, the better. But I do think that you don't want to have houses that are too big, because then, you don't have that chance to really become connected. All right, we do have a question that came up. What about shared rooms as opposed to private rooms? Actually, they're both very good. Sometimes we've noticed houses, people start out with shared rooms, and as they live in the house longer, they can graduate to having individual rooms. So I think both can be appropriate for the person. We had another question that came up before that one.
Yeah, it looks like Adina was looking for some information about resident age, specifically residents over 55, and that kind of relationship with Medicare coverage and recovery living. I don't know if that's anything we've looked at in the past, Dr. Jason.
We have a data set of about 60,000 people that have applied to kind of live in recovery homes. And one of the questions was age. And we're looking at kind of the age variable. So that is something that we can kind of get back to you. But it is an important variable. Certainly there's a kind of a sense of, it's not just the age, but it's also readiness to kind of really make a change. And whether that's someone who's younger, in their early 20s or older, 50s and 60s or older, whether they're really at that point where they're saying they've had enough of that lifestyle that has, produced so much pain and difficulties. So that's really a readiness issue. But certainly when a person's ready, that's really the best time for them to come into these recovery homes. We had another question that came in.
Yeah. There's one from earlier I just saw in the Q&A portion in the chat. It seems like Tiffany was looking for she's trying to encourage residents to stay at least 18 months. And she's saying that they feel better, they get a job, and they believe they can tackle the world. and then they find out they can't, seems like post leaving the home. Is there, I don't know specifically question wise, but
Well,
is
I
it,
mean, it could be that a person needs to stay in that type of protective setting for a longer period of time until they are ready. So, truthfully, it is variable in each individual. Liz has had a lot of experience with treatment. Wondering, Liz, do you have a sense of kind of what your thoughts would be on that issue?
Yeah, most definitely. I've worked as an addiction counselor, working with folks that are like through the rehabilitation phase, like those 28-day programs, and then helping set up with services later. I've noticed whether it's someone that is doing a furlough or is kind of a part of the criminal justice system, that might have mandatory drops that they're making or meetings that are required for their program. It can be really important whether it's a staff member or a peer to help support them in that process. I know some things like transportation, just finances can be really tough when starting out in a new house. Sometimes having a lot of responsibilities can also be very overwhelming. So, even a space where someone can air out their frustrations, whether it be with a staff member or a peer, I think that can really help someone with confidence in remaining within the home and feeling like, despite there being challenges, someone is there to support them and help them work through it.
And I noticed that Paul Stevens gave his email address. Good to have you out there, Paul. Paul is very connected leadership role within the Oxford House community. And one of the nice things is that kind of NARR houses and Oxford houses, they're working so much closer together on so many things that are so important for recovery. And a lot of the ideas that we get are really from places like this, where we have a chance to interact with folks who are part of the recovery community. And even what Liz just, had shown you, her kind of different kind of stages of recovery homes. That really was an idea that one of the leaders of the Oxford House community actually developed. So we just tried to really operationalize it. So really, the ideas, the generative material of what's important from so many people, Dave Sheridan and Paul Malloy, Kathleen Gibson, so many other people, um, from so many places have been so instrumental in kind of setting our direction. So we are always wanting to hear from you as to what you think kind of are importance. It's interesting that that tolerance study that we did really came from kind of a person at a convention that came up to us and said, you folks should study tolerance because that's one of the more important things that happens when we live in these recovery homes. We become better people, more able to see differences in ourselves and others. So we did that as really something. A NARR summit in Florida in September. Well, thank you, Robert, for telling us about that. Do send us information, and it sounds like a great event. So thank you for kind of letting us know about that. And I know that that's kind of one of the big meetings of the year. So thank you for that information.
Dr. Jason, we had a really interesting study idea kind of pop up in the chat. And actually, it connects to some of our older studies a little bit. But Alex put in there study, great name, by the way, one of the best names. Alex wanted to know about the study on the direct economic benefit of workers in the economy from recovery house, and they're no longer being in the criminal justice system. I know we've been trying to get involved in some of these drug court studies and stuff like that, and this is a really good question because we know one thing about government funding and stuff like that. They love when we try to show a way that they're using less of the government resources. So I feel like this is an interesting perspective. I want to hear if anybody has a perspective on that.
Yeah, it's interesting when we think about outcomes. I think a lot of us think about sort of the mental health. Are people able to be more independent, autonomous? Are people able to have more personal growth? Certainly being abstinent, um, having other kind of connections. All these things are important, but the policy people really are much more interested often in, well, does it save us money? Is it economical? If we put resources into this, are we going to get something back? And that's okay, that's fair. If that's what they want, that type of information, then there's nothing wrong with us trying to gather information because truthfully, the economic benefits are amazing. When you think about the costs where people are often working, supporting themselves, supporting their families, trying to basically make a change in their life, what a tremendous contribution that is to themselves, their family, their community. And the economic benefits are there. As I mentioned, when we looked at control conditions um, versus those who came out of criminal justice, when people come out of criminal justice, they're often basically having two very strong needs. One being they want a safe place to live, and the second is they want an opportunity to make enough money so that they can support themselves. So, yeah, something like $34.57 return on every dollar invested. That's an incredible. So, thank you for sharing that. But you're right. We've got cycles, 600,000 people coming out of criminal justice settings. So those individuals need a safe place so that they can be around folks who are modeling behaviors involving good working, not criminal involvement, being around people who are not using drugs or alcohol, illegal drugs. If you thought about the economic benefits of these settings, thousands and thousands of settings across every community, that's really an inexpensive way of changing lives. Um, and I'm just so happy that places like the iStar group, which some of you know about, um, is trying to basically encourage kind of people who are healthcare workers and researchers to kind of come into this field and really begin to study it. Um, we're working right now on writing a grant proposal, and the first person we thought of to bring into the research was an economist at Northwestern, because we said we really want someone who's a health economist who can quantify the results so that we can basically say, well, if you basically spend this amount of resources, this is what society can get back. So I think that, yes, the more research that we can have that brings into this particular economic piece, it's very important at the policy level in terms of what's needed. So thank you for bringing that issue up, and we certainly have been kind of most interested in that issue for many years.
Yeah, and then folks were asking for whose email they can reach out to from the team. I put my email in the chat. It's asecora3@depaul.edu. Feel free to send me all your messages, and I can be able to pass them along, connect them to other folks along the team. We had another question kind of talking about, or really just a statement. I would like to see other people's perspectives on this from Casey. As a recent drug court graduate, therapeutic court and behavioral modification is the theme in the workbooks, which isn't too beneficial. The structure and accountability is what benefited me most, and they're always asking and encouraging support outside the program. I don't know if anybody has any initial reactions or thoughts to that, or
Well, it's a good point. I know that Carly has a particular interest in criminal justice. Carly, any thoughts on that issue?
Well, it's just interesting to hear your perspective from being someone who's moved through those drug court programs. So that's cool to hear about your experience.
And we have one of our kind of former members of our team, Justin, who basically has published a paper on drug courts and their connection with recovery. And it's a nice qualitative study. And there's other people that have done some interesting work that was profiled in our slides. Jody is another person who has done some nice work supported by the iStar network. So yeah, all good stuff. We probably have time for maybe one more question before we let you all go. But we certainly appreciate the time that you've given us so that we can share with you some of the work that we've been doing over the years. And we certainly appreciate. Well, thank you, Jessica. We appreciate your kind comments. And any comments from our panelists that you'd like to, this is for some of our group, their first time they've had a chance to present. So thank you for allowing us to kind of share this forum with you. And we'll just go around and each person can give you their thoughts about what they got out of this presentation. I'll start out with Alexander. How did this go for you?
Well, I thought it was wonderful, and thank you all for your comments. And I'm really interested in this Fletcher group. It's been in the recovery space for 4 or 5 years now. I haven't heard too much of it, but it seems like they're doing some interesting things. So I may be reaching out to some of you out there about that. But I love this. I think the main takeaway is we talk about a lot of different aspects of how recovery housing are supportive, and I think the important thing is the houses are bringing together individuals with a shared goal, and that seems to give people the biggest benefit. You could try to white knuckle it on your own all you want, but that community aspect of recovery seems to be one of the most important we see consistently through all of our findings. So, and thank you all for listening to all of us.
Thank you, Alexander. Liz, how about yourself? How did this go for you?
Yeah, most definitely. It was really wonderful to hear from everyone. Just even some of the comments, truly your input is so valuable. As researchers, a part of what we do is we want to hear from the communities. We want to know what questions need to be answered. And I think we've definitely talked about some studies potentially with drug court in the future, which is an exciting avenue for us as well. So really thank you so much. And we hope that, we have definitely gained so much from this, and we hope that maybe that is shared as well. So very much appreciate it.
All right. Well, thank you, Liz. Carly, how about yourself?
Well, as you mentioned, this was my first time speaking on any sort of panel or anything. So thank you everyone for kind of giving us the time and space to talk with you today and kind of share what we've learned. As Liz and Alexander said, we're really grateful for you guys sharing your perspectives and your experience and your questions and just being here with us today. So thank you.
All right. Thank you, Carly. And thanks for letting me put you on the spot there for a second. You did fine with your response. Angelina, how about yourself? Kind of how did this go for you? And is this the first time you've done something like this?
This actually is my first time doing something like this, but I really appreciate everyone taking the time to listen to me and allow me to present something for you all. And I've also been working on a paper about MOUDs for the past 2 or 3 months, and so it was really rewarding to be able to hear everyone's answers to my questions. I noticed someone said something about treating everyone the same, and then someone else mentioned that with MOUDs, they make it an option to make other residents aware that you're even taking MOUDs. So I didn't know that. And it was just, yeah, really rewarding to be able to hear even though it's virtual, what other people who have direct experience with recovery homes have to say about our research. So thank you all so much.
Thank you, Angelina. And Aron, how about yourself? What's your thoughts for the afternoon?
I think it's great. Like Carly, this is my first time speaking on a panel. But yeah, I just want to say it's a really valuable experience. Thank you for your time and consideration. As a graduate student, when you do research, you often just look at like what kind of phenomena there is, right? You don't really think too much about it, but not so often you have to think, what can other people do about this? What can you do to improve it? What are the things people can do? So this certainly is a really good lesson for the future.
Well, thank you, Aron and Liz, Carly, Angelina, Alexander. It's really a treat for me to see all your performances and how you just weaved all your ideas into this. And I'm kind of amazed at how much overlapping kind of ideas came through this because we really didn't have a practice session. So thank you all for listening to our first time we did this. So I think we're going to take this on the road. I'm not sure where we're going to go, but it's so much fun. We won't stop here. Elliot, we're going to turn things back to you. And all we can say is thank you and the NARR organization for the opportunity to participate in this. And, we certainly have benefited tremendously from all the support that we continue to get from the NARR organization. And for those of you part of the Oxford House organization, we appreciate so much all the help that that organization has provided us over the years.
No, thank you so much. Of course, thank you, the Paul group, for joining and presenting, and thank you everyone for joining as well. I think we had a turnout of 68 participants, give or take a few AI, so I'm really grateful for the number. And the main takeaway that I took away from the presentation was the importance of collaboration and how that can, translate into success. So again, I'm really grateful that we have such a collaborative webinar. So again, thank you for everyone, the Paul group and the audience, and hopefully I'll see you all in our next webinar.
Bye-bye.
Bye-bye.